Good day. This is Dr. John Bennett broadcasting from the wilds of Miami, sunny Miami. Today we have another show in the Radiologist.tv station. We have with us today three members of the panel. Fake Shaikh, MD, a molecular imaging physician by training and an informatics fellow at the University of Pittsburgh Medical Center and the co-founder of this Radiologist.tv channel. In addition, we have Simon Downs, MD, a medical student from Japan, my main man, and Fred Van Gestel, a medical student from Belgium. And the speaker today is Omer Awan MD, assistant professor of radiology at the Geisel School of Medicine at cold Dartmouth, warm now. Also the assistant director for the radiology residency at Dartmouth. And Omer also gave a show on the 29th of August on radiology informatics, which can be seen at the website radiologist.tv in the shows section. And I'll let Omer take it away.
All right, so this is a talk on primer on cervical spine trauma. This is a sort of introductory lecture to, from a radiology standpoint, on how to assess the cervical spine, and often as residents and fellows who are training, it's difficult. The cervical spine can be a very challenging topic in terms of figuring out what is going on and what type of injuries there are, what type of mechanism is going on, whether it's a hyperflexion injury, hyperextension injury, and that sort. So this talk is going to help demystify those concepts and try to give everyone sort of a basic understanding of how to approach the cervical spine in terms of trauma. So I always start my lectures off with some basic questions and 4 or 5 cases that are sort of unknowns. Typically my residents take these cases, so I'm just going to show 5 cases very briefly. We'll obviously come back to these cases at the end of the session. So this is case 1. There's obviously a gross abnormality in the cervical spine here. So just mentally try to figure out what's going on and what you think the diagnosis is. So that's case 1. This is case 2. This is a different patient that has an abnormality in the cervical spine at a different level as well. So mentally just try to figure out what you think the diagnosis is, or the differential diagnosis is, for this injury. This is case 3. This is a sagittal CT of the cervical spine. This is a completely different injury. And I have a follow-up question based on that. So based on that image, the injury just shown is associated with which of the following? Is it a hyperextension mechanism? Is it an anterior cord syndrome, central cord syndrome, or is this associated with a mesenteric contusion? This is case 4. This is another cervical spine injury, a different injury than any of the ones that I've shown thus far. 2 lateral radiographs of the cervical spine. And the last case is an axial CT image of the cervical spine at the level of C1/C2. Demonstrating a different injury, and a follow-up question to that is the mechanism of this injury is it axial loading, hyperflexion, hyperextension, hyperflexion distraction, or is this rotary subluxation? Okay, so those are my sort of pre-quiz or pre-cases before we start the talk. So the objectives today are essentially we're going to define basic measurements that help determine if the cervical spine injury has occurred. Okay, so there's a ton of measurements that we typically use in the cervical spine based on radiography and CT, but we're only going to talk about some of those things and the things that I think are the most important when assessing the cervical spine. We're going to elucidate the role of various imaging modalities in cervical spine trauma, particularly CT, radiography, and MRI, and their utility for diagnosing the spine trauma. We're going to characterize basic cervical spine injuries by mechanism and imaging, and then finally we're going to discuss the differences in imaging between the different cervical spine injuries and how to differentiate those and come to a definitive diagnosis on what exactly is injured. So first we're going to define basic measurements. And before we talk about measurements, we really have to talk about the alignment of the cervical spine. So if one looks at a lateral x-ray of the cervical spine, there's really 3 lines that one should pay attention to. One is the anterior cervical spine line, or what the line that corresponds to the anterior longitudinal ligament that is along the anterior aspect of the anterior vertebral bodies. This line should be completely straight. If there's any deviation or if there's any break in that line, then an injury to the cervical spine has occurred. There's a line along the posterior bodies that corresponds to the posterior longitudinal ligament that should also resemble a pretty straight line. If there's any disruption of this line, then a cervical spine injury has occurred. then finally the spinal laminar line, which is the junction between the lamina and the spinous processes. This should also be a relatively smooth line. If there's any break in this line at any level, a cervical spine injury has occurred. So that's pretty much the first thing that I do when I look at a cervical spine X-ray. I make sure that I can see C1 to C7, all the 7 vertebral bodies, and then I assess these lines and make sure that they're completely intact and there's no break in those lines. So that's a basic fundamental concept to cervical spine imaging. In terms of measurements, everyone has sort of different measurements and different thresholds depending on what literature you read and what papers that you cite. But what I use is, for prevertebral soft tissue swelling, prevertebral soft tissue swelling can really give you a hint as to what is going on in the cervical spine. What I use is at the level of C2, if it's greater than 5 millimeters at C2, or if it's greater than 15 millimeters at C5, then I call that prevertebral soft tissue swelling. And note that prevertebral soft tissue swelling isn't specific for cervical spine injury. Other things such as retropharyngeal abscess, things that are completely unrelated to cervical spine, can also manifest with prevertebral soft tissue swelling. But in the setting of trauma, like in a patient that has a motor vehicle collision or has fallen or something like that, prevertebral soft tissue swelling will give you a hint as to the fact that some sort of trauma has occurred to the cervical spine. It may not be a fracture. It may be ligamentous injury for which an MRI will elucidate that etiology, but it gives you a hint as to that something has gone on. The atlantodental interval, which is the distance between the dens, or the C2, and the atlas on a lateral view, it should be less than 3 millimeters in adults and less than 5 millimeters in children. Okay, and the Bayesian axial index, which is essentially the interval between the tip of the dens, or the C2, and the base of the Bayesian. That should be less than 9.5 to 12 millimeters on a lateral view or a CT, okay? So what we mean by this is this. So the atlantodental interval is this space here. So between the dens, the C2, and then the anterior arch, essentially, of C1. That should be less than 3 millimeters in adults, less than 5 millimeters in children. And then the interval between the tip of the odontoid process, or the dens, and then the Bayesian, this interval here should be less than 9.5 to 12 millimeters right there. And prevertebral soft tissue swelling I would measure right here. C2 should be less than 5 millimeters there. And then at C5 it should be about less than 15 millimeters here, okay? That's kind of how I measure stuff. Note that in children, the measurements can be a little different. So prevertebral soft tissue swelling, you're allowed up to 6 millimeters at the level of C3, okay? So in children, the measurements are going to be a little different. That's just my basic rule of measurements. There's a ton of other measurements, like the Powers ratio and other measurements that I did not get into. For the purposes of this talk, this is a basic talk, and we're just going to talk about those basic measurements. Now we're going to elucidate the role of various imaging modalities in cervical spine trauma. So pretty much, we used radiography, CT, and MRI, and they all have different uses and utilities, okay? So radiography, or X-rays, we use for initial evaluation. Anytime a patient comes in with suspected cervical spine trauma, they get put into a collar and they get an X-ray, an AP, a lateral, sometimes flexion extension views, depending on how severe the injury is, and open mouth odontoid views, okay? This is for the initial evaluation to see if there's any fracture, any prevertebral soft tissue swelling, malalignment of the cervical spine, okay? It's the best initial test to assess the cervical spine. CT is very good to assess for fractures. It really delineates exactly what is fractured, how many fractures there are. Sometimes we miss fractures on radiography, subtle fractures that we then see on CT. We can assess the spinal canal for patency to make sure that there's no retropulsion of fracture fragments, and prevertebral soft tissue edema is easily and readily assessed on CT. MRI is really good, really for the ligaments. So, when we have ligamentous injury, we can't see that on an X-ray or a CT, but we can definitely see the anterior longitudinal ligament, posterior longitudinal ligament, the ligamentum flavum, interspinous, supraspinous, ligamentum nuchae, the alar, apical, transverse ligaments, all the ligaments that are necessary for adequate function of the cervical spine we can see on an MRI. We can see cord contusion or increased T2 signal within the cord itself. We can see traumatic disc herniations much better on an MRI. So MRI is really an advanced imaging to find out what else is going on in the cervical spine. So now we're going to characterize spinal injuries by mechanism and imaging. That's going to be the next thing that we do. And really, there's many ways that we can characterize these, but what we're going to do is we're going to talk, and there's I have atlas C1 injuries, axis C2 injuries, and then the subaxial spine. And there's more than just a Jefferson Burst fracture for C1. There's more than just a Hangman's fracture for C2. but we're just going to keep it really simple and basic for today, just because for time constraints and just as an introductory lecture. So, in terms of the atlas, the C1, the typically the most taught fracture is a Jefferson Burst fracture. This is an axial load injury to the C1 ring. Okay, characteristically, it's broken in, because it's a ring, it has to be broken in at least 2 places, but characteristically, it's broken in 4 places, 2 places in the anterior arch and 2 places in the posterior arch of C1. Classically, this is a stable fracture. It can be unstable depending on if the transverse ligament is disrupted, and we'll talk about that a little bit later. So this is what a Jefferson Burst fracture looks like. This is a cartoon here, which shows the C1 ring. This is not a classic Jefferson Burst because this is a 3-part fracture where you have 2 fractures along the anterior ring right there, but then 1 fracture along the posterior ring. A classic fracture would also have a fracture right here to make this a 4-part Jefferson Burst fracture. And here we see essentially a 3-part fracture with 2 here along the posterior ring and 1 along the anterior ring here. So this is a Jefferson Burst fracture, okay? In terms of assessing for stability, so the transverse ligament, as you know, runs between essentially beneath the odontoid process along the anterior aspect of the C1. So if you have greater separation between the tip of the dens and the lateral mass of C1, if this distance between here and here is greater than 7 millimeters, that means that the transverse ligament is disrupted, and that is an unstable fracture. So that's an important measurement to note too. If it's greater than 7 millimeter separation between the lateral mass, one of the lateral masses of C1 and the odontoid tip, that means that the transverse ligament is disrupted. Okay, a pseudo-Jefferson fracture can be seen in children up to 7 years of age. It's not a real fracture, but it can be confused for a Jefferson fracture. You can have up to 6 millimeters of displacement of the lateral mass of C1. So again, this is an open mouth odontoid view. This is C2. This is the odontoid process of the dens. These are the lateral masses of C1. You can have up to 6 millimeter displacement of the lateral mass of C1 relative to the dens, okay? And that's a normal finding, okay? So that's what we call a pseudo-Jefferson fracture. Going to the axis, again, we're going to talk only about the hangman's fracture, but there are many types of C2 fractures, like the 3 types of odontoid fractures, which we're not going to get into here. But a hangman's fracture, pretty much classically, is a bilateral C2 pars interarticularis fracture. Okay, this is characteristically, it's a stable fracture. The mechanism usually involves hyperextension and axial loading, but there are different types of hangman fractures, which the Effendi classification addresses. There's a type 1, type 2, type 2A, type 3, and different fractures have different mechanisms. For example, a type 2A is actually a hyperflexion distraction injury, and there's the different mechanisms a result of the different degrees of angulation and translation that are associated with a hangman's fracture. So the classic hangman's fracture, which is simply a bilateral C2 pars interarticularis fracture, involves hyperextension and axial loading. And we just talked about this. So this is a classic hangman's fracture. You can see on the axial plane there's a fracture plane that goes through the entire pars interarticularis bilaterally. You can see that on the lateral view of the cervical spine. This lucent line here is through the pars interarticularis there. Same here, pars interarticularis. This was actually the first case, I think, that I showed on my pre-quiz assessment. So this is a hangman's fracture or a C2 fracture, okay? Hyperextension with axial loading, classically stable, okay? So this is just a question. So if a hangman's fracture involves a transverse foramen, what would the next best step be clinically? Should we get a CTA? Should we get an MRI to evaluate for cord compression? Should we call a surgeon? Or should we assess for bowel injuries? The answer here is going to be a CTA because the transverse foramen, as you know, holds the vertebral artery. The vertebral artery goes through the transverse foramen from C6 to C2. So we want to assess the integrity of the vertebral artery and make sure that there's no underlying dissection, so we would get a CTA study, okay? Now we're going to talk about the subaxial cervical spine, so anything from C3 to C7. And now note that hyperflexion and hyperextension injuries don't necessarily only happen at C3 to C7. They can happen at C1. They can happen at C2. In fact, a hyperextension teardrop fracture most commonly does happen at C2. But just for the purpose of this talk, we're going to talk about hyperflexion, hyperextension injury, and group them into the subaxial spine here. So talking about hyperflexion injuries first, this is sort of a continuum of injuries. The least serious hyperflexion injury is a hyperflexion sprain, and then we can go down and talk about anterior subluxation, pseudo-subluxation, facet dislocation, and then flexion teardrop fracture, which happens to be the most serious type of hyperflexion injury, and probably the most serious type of cervical spine injury in the entire cervical spine. So one note about hyperflexion injuries, it's important to note that they represent a spectrum of injuries. Okay, hyperflexion sprain, as we said, is the least severe, and it's interesting to note that when we talk about ligamentous injury for hyperflexion injuries, it's interesting to note that, or it's easy to understand that the ligamentous injury usually progresses from posterior to anterior, whereas when we talk about hyperextension injuries, the ligamentous injury is going to progress anterior to posterior. So that's a very important teaching point, that when we're talking about flexion injuries or hyperflexion injuries, we're talking about ligamentous injury that occurs posteriorly in the spine and then progresses anteriorly. And I'll tell you what I mean by that. So when we look at the cervical spine, so the anterior longitudinal ligament is this ligament here that coats or abuts the anterior aspect of the vertebral bodies. The posterior longitudinal ligament is the ligament that abuts the posterior aspect of the vertebral bodies. Then you have the ligamentum flavum right here. Okay, this is part of the posterior ligamentous complex. The interspinous ligament are the ligaments that run between the spinous processes. Then you have the supraspinous ligament, okay, which abuts the tips of the spinous processes. But in the cervical spine, this is called the ligamentum nuchum, or the ligamentum nuchae, and then in the thoracic and the lumbar spine, it continues as a supraspinous ligament. So this is actually the ligamentum nuchae in the cervical spine. Okay, you have other ligaments that we're not really going to talk about, like the alar ligaments, the apical ligaments, the transverse ligament, which we did touch on, the anterior and posterior atlanto-occipital membrane. But for the purpose of this talk, we're going to talk about these ligaments, and it's important to note that the spine is broken down into 3 columns. Okay, so one column is the first half of the anterior half of the vertebral body, which includes the anterior longitudinal ligament. That's the anterior column of the spine. The middle column refers to the posterior half of the vertebral body and the posterior longitudinal ligament. Okay, that's the middle column. And the posterior column, the posterior ligamentous complex, includes all the other ligaments. So the ligamentum nuchae, the supraspinous ligament, the interspinous ligament, the ligamentum flavum. Okay, so there's 3 separate columns in the cervical spine. Okay, or the thoracic spine or the lumbar spine. The key is that a lot of residents and fellows ask me, well, what do you need to call an unstable injury? And a lot of residents don't understand this, but really, for there to be an unstable cervical spine injury, 2 out of these 3 columns that I just explained have to be injured. So if you only have one column that's injured, like the anterior longitudinal ligament is disrupted, but nothing else is disrupted, that's not an unstable injury. If you have solely the posterior longitudinal ligament that's disrupted, that's not a stable injury. Let's say one has the ligamentum nuchae is injured, the interspinous ligament is injured, and the ligamentum flavum is injured. Is that unstable? The answer is no, it's not unstable, because that's still, all those 3 ligaments are only one column. That's the posterior ligamentous complex column. That's the posterior column of the spine, because the anterior and the middle column are not injured. So even though you have 3 ligaments that are injured, that's still not an unstable injury. Okay, so you have to have 2 out of the 3 columns to be completely injured, and that's what we call an unstable injury. So that's a very crucial teaching point for the cervical spine. So hyperflexion injury imaging. What are we looking for on radiography or CT to diagnose hyperflexion injury? Well, one thing is that you look for the widening between the interspinous or the spinous processes. If there's widening of that distance, then that's a clue that there is hyperflexion injury. If there's widening of the posterior intervertebral disc space, that is a clue that there's hyperflexion injury. If there's anterior subluxation of the vertebral bodies with respect to another, that can also be a clue that there's hyperflexion injury, but not necessarily. So this is what a hyperflexion sprain looks like. Notice here that there is there's only disruption of the posterior ligamentous column, so this is a stable lesion. Okay. Notice that there's widening of the interspinous distance, or distance between the spinous processes here at this level at C5 and C6. So this would be a hyperflexion sprain at this level right here. Okay. This is anterior subluxation, where we have anterior subluxation of a vertebral body with respect to another vertebral body. There's focal kyphosis at this level, and there also is, notice that there's no definite facet, perch facet or jump facet, but there is diastasis of the facet here between the inferior articular facet at C4 and the superior articular facet at C5. Okay, so this is an unstable lesion, because this is not only involving the there's widening of the disc space here, and there's posterior disc space here, and there's widening of the of the interspinous systems between the spinous processes here. So this involves not only the posterior ligamentous complex, but also the posterior longitudinal ligament, because there's anterior subluxation of a vertebral body. So this is involving 2 out of 3 columns. This is an unstable injury. Pseudo-subluxation is something that we see in the pediatric population, typically in kids that are less than 7 or 8 years old. It results in apparent subluxation of C2 on C3 or C3 on C4, but this is not a real subluxation, because this happens because of incomplete ossification of the upper cervical spine. And the key to making this diagnosis is that the spinolaminar line is completely intact. So remember, we talked about the lines in the C-spine. Here on this flexion view of the cervical spine, it looks like the C2 is subluxed over, that there's anterior subluxation or anterior translation of C2 on C3, but if you assess the spinolaminar line, it's completely intact. Okay, the spinolaminar line is completely intact, and that shows that this is actually not a real fracture or not a cervical spine injury, but this is a normal variant that we see in the pediatric population. Okay. Unilateral facet dislocation is a step up above what we've already been talking about. Notice here that we have a facet dislocation. The facet. So this is not quite here at this level. This is not quite on the far right image. This is not quite a perch facet or a jump facet, but this is diastasis of the facet, because the facet, the superior articular facet at this level where the arrow is, should really be right here where my mouse is, okay, articulating with the inferior articular facet with the of the vertebral body above. Here we have a jump facet at the leftmost image, because the superior articular facet of the vertebral body below the level should be anterior to the inferior articular facet of the vertebral body that's above. But here we have the superior articular facet noted to be posterior to the inferior articular facet from above. So this is actually a jump facet. Okay, so this is a facet dislocation, and you notice that you have at least 50% anterolesthesis of C4 on C5 due to this facet dislocation. You can have bilateral facet dislocations. Again, this is a jump facet. This facet is projecting the superior articular facet of 2, 3, 4, 5. C6 is posterior to the inferior articular facet of C5. Okay, there's at least 50% anterior translation or subluxation of the C5 vertebral body with respect to C6. So this is a bilateral facet dislocation with jump facet. Okay, and the hyperflexion teardrop fracture is probably the most severe form of spinal injury one can have. Typically, this happens at the C5, C6 level, but not always. You have usually an anterior-inferior teardrop fracture fragment from the vertebral body, as we see here, and then we also see retropulsion of the vertebral body into the canal here, okay, resulting in moderate to severe canal narrowing. So this involves all 3 columns, right? It involves the anterior longitudinal ligament, posterior longitudinal ligament, and then the posterior ligamentous complex as well is disrupted. So this is an extremely unstable injury that we see. So hyperflexion teardrop fracture, what is it associated with? Is it associated with the anterior cord syndrome, or is it associated with the central cord syndrome? And the answer is that it's associated with the anterior cord syndrome, okay? This is just a cartoon depicting hyperflexion injuries, okay, which we already talked about: hyperflexion sprain, facet dislocation, unilateral, bilateral, and then a flexion teardrop fracture, okay? Moving on to hyperextension injuries. These are a little different. These are much different than hyperflexion injuries, okay? These range from hyperextension sprain to hyperextension teardrop fractures. And contrary to hyperflexion injuries, hyperextension injuries, the ligamentous injury propagates anterior to posterior as opposed to posterior to anterior, as we saw in hyperflexion. So again, the anterior longitudinal ligament is going to be the first ligament that's going to be disrupted in hyperextension injuries, okay? And the findings are a little different too. So remember that in hyperflexion injuries, we talked about, widening of the interspinous processes or the posterior intervertebral disc space, but here we're going to have widening of the anterior intervertebral disc space. That's going to be a clue that there's hyperextension injury. And we're going to have facet malalignment, which we can also see in end-stage hyperextension injury. So here, again, this was one of the index cases earlier. Notice that there's no fracture in this cervical spine radiograph, but there is widening of the anterior disc space here, and this is a hyperextension sprain, okay? Hyperextension teardrop fracture characteristically happens at C2, okay? You again also have, just like in hyperflexion teardrop fracture, you have a fracture fragment along the anterior inferior aspect of the vertebral body, but notice that there's no retropulsion of the vertebral body into the canal. That we see in a hyperflexion teardrop fracture. We do not see that in a hyperextension teardrop fracture. Okay. Classically, again, this is another sagittal and axial CT image of the cervical spine. We have at C2 we have a teardrop fracture fragment, but no retropulsion of the C2 vertebral body into the canal. This is a hyperextension teardrop fracture. Okay. This is associated with a central core syndrome as opposed to the anterior core syndrome. Okay. This is characteristically stable in flexion, but it can be unstable in extension, because what happens in extension is that it propagates not only from the anterior longitudinal ligament that's already disrupted, but it can also disrupt the posterior longitudinal ligament and the ligamentum flavum. So it becomes an unstable injury in extension. Okay, so this is a hyperextension teardrop fracture. Okay, so that's pretty much my talk. Sort of a primer on cervical spine. Hopefully that gives you a better way to assess the cervical spine. Coming back to our index cases. So this case 1, notice that we have a lucent line through the pars interarticularis at C2. This is a classic hangman's fracture of C2, done from hyperextension and axial loading. Okay. Case 2 is what we just saw, widening of the anterior intervertebral disc space, seen in a hyperextension sprain. No fracture was seen here, but just widening, consistent with hyperextension sprain. This is a hyperflexion teardrop fracture. Notice that we have focal kyphosis here at the level of C5. We have a anterior inferior fracture fragment. We have retropulsion of the fracture fragment into the canal. This involves all 3 columns. This is a hyperflexion teardrop fracture. This injury is associated with the anterior cord syndrome. Okay. The central cord syndrome would be associated with a hyperextension teardrop fracture. This is not a hyperextension mechanism. This is a hyperflexion mechanism. Okay, and then mesenteric contusions are typically associated with chance fractures, which is a completely different type of fracture that we did not discuss today, typically seen at the thoracolumbar spine junction. This is case 4, where we have bilateral facet fracture dislocation with jump facets here and anterior translation of C5 with respect to C6. Okay, and the last case is an axial CT showing a Jefferson Burst fracture, which we showed as well earlier. So a fracture of the C1 ring, 2 posteriorly and at least 1 anteriorly there. Today, I hope what we've done today is we've defined basic measurements that help determine if cervical spine injury has occurred, namely if for prevertebral soft tissue swelling, at C2, it should be greater than 5 millimeters. At C5, it should be greater than 15 millimeters. Looking at the Bayesian dental interval, making sure that it's, it should be less than 9.5 to 12 millimeters. Those were some of the measurements that we used to characterize the cervical spine. We elucidated the role of various imaging modalities in cervical spine trauma. So radiography is the initial assessment to assess the cervical spine to see if there's any prevertebral soft tissue swelling or fractures. CT is the best at identifying fractures. And MRI really is good for ligamentous injury or traumatic disc herniation and cord contusion and things like that. We characterize cervical spine injuries by mechanism, particularly we looked at C1 fractures, C2 fractures, and we differentiated hyperflexion and hyperextension injuries. And we talked about the various differences in imaging between these injuries. For example, hyperflexion injuries typically involve existence in the posterior intervertebral disc space, whereas hyperextension injuries characteristically involve widening of the anterior intervertebral disc space, among other things. So these were my references for the talk, among others.
Do we have the audio there? The audio. Oh. Do we have an audio? Are you guys getting the audio okay?
No, I'm not hearing anything, John.
Yeah, okay. I guess we're losing him. Okay, Flake, go ahead. You can lead the discussion.
Well, I'm not sure if Dr. Awan is able to hear us right now, but this was a very thorough and very, very well put talk on, the introduction to cervical spine. I, being a molecular imaging physician, have very little exposure to, emergency radiology, but I know that this is a complex topic, and to lay a foundation in it in a clear fashion is essential to have. So Dr. Awan, can you hear us now?
Not yet. Yeah, until he gets on, Mike. You know, as an emergency physician, I know that knowing that C-spine radiology is so important because those are X-rays you don't want to miss. You don't want to miss anything on that, and you want to be over conservative. You know, everyone that has any possibility of having a C-spine injury gets immediately immobilized until you can prove it doesn't exist. And this is to the students. You have to know it very well. All the things that Dr. Awan was talking about, the subtle soft tissue injuries, and Frank, you might be able to comment on this. A lot of times when you're looking at X-rays in the ER, you can't really see bony things, but you know, it's looking at these subtle soft tissue signs. Can you comment about that, Mike?
Yeah, well, the thing is that, of course, X-ray is the first line of imaging. You get it, you know, an ambulatory X-ray right there in the ED. That's the first way to assess the injury whenever there is a MVA or any kind of trauma that the patient comes in with. But of course, we have the CTs that are actually the best modalities for detecting fractures. But when it comes to soft tissue injuries and soft tissue abnormalities, of course, MR is superior to CT in that regard. MR takes longer, and I think Omer just messaged he's having trouble. Oh, there he is.
You know,
can you hear us?
I was going to ask Omer this, like maybe you and Dr. Sajid can comment. But Omer's back. Can you hear us, Omer? Having audio. You can unmute yourself, Omer, please. Unmute. You're muted. Well, maybe you can comment, like, until Omer gets his sound back up. Is that the activities, I guess, that are most common with fractured necks is probably number one, car accidents, correct?
Well, car accidents, yes. There's soft tissue injuries with that. There's whiplash, and then there are, of course, hyperextension injuries, and of course there is assault as well. Right. Depending on what kind of population you're serving, you can have quite a lot of that. I was in the Bronx doing my surgery internship, so we did see a lot of those. And I would have liked to open the floor and have the students ask questions if they had any.
Okay. Frederick, Jesse, any questions?
No, not really. Yeah, the audio was a bit jacked up, but it's all right now, I think. Yeah, it was a really interesting. Sometimes a bit fast for me to follow, but it went all right. Yeah, I learned a lot. Yeah, very interesting. Not really any questions. Hoping to see more of you guys.
Okay, very good. Thank you. Jesse, any questions at all?
Yes. Now, I just wanted to say that, given the fact that we are having trouble with the audio right now, we can always, of course, the hashtag Radiologist TV, is open where you can leave comments and questions, which we can definitely follow up on. And by the way, Dr. Lam has also joined us from Lahore, Pakistan. He, Sajid, can you hear us? I know he's muted, but
there's a count.
Okay. Well, it looks like there has been a couple of audio issues all of a sudden, but the good thing is that we were able to get through the talk. Yeah. So again, thanks to all of you for joining in, and please leave your comments and questions, which I'll be sure to follow up on. And then we are working hard to bring more quality content to you guys. We have a talk lined up on interventional radiology by Dr. Syed. That's going to happen sometime in the next couple of weeks. There's a talk by myself on thyroid cancer management that should not be too far away either. And of course, Dr. Rai, the cardiac imaging contributor here at Radiologist.tv, is already working on his next talk as well. So if we have a nice lineup of future talks coming up, so keep posted.
Great job, Fight. Keep that great content coming.
Yes, we are working hard towards that. And again, thanks all of you for joining in, and have a nice day.
Thank you.